Very good morning to all of you. So the next three Friday lectures will be from adult hematolymphoid, and we have kept three lymphomas. We have already had a class on DLBCL, so now next three lectures will be on I would say rarer lymphoma. So today's lecture is on uh, mantle cell lymphoma. So the objectives of today's lecture is to discuss about the epidemiology, prognostic factors, and what are the different uh, approach in mantle cell lymphoma depending on the patient profile, whether it is weight and watch, limited stage disease, young and fit patient, elderly or unfit, and in the relapsed refractory group. And then we'll discuss few unanswered questions in mantle cell lymphoma. Now, coming to the epidemiology of mantle cell lymphoma, as you can see, it is a rarer lymphoma. 3 to 10% of all NHL that we see. In our TMH data, long time back, it was 2 to 3%. There was data from AIMS also, it is around 5% of all the NHL that you're going to see in your OPDs. It's a disease of elderly. The median age is 60 years and a bit of male preponderance. Now, the external sites are quite different in mantle cell lymphoma, as you can see from this diagram, where we have predominant GI tract involvement. In clinical involvement or patients with clinically involvement of GI tract is around 25%, but in subclinically, almost 80% of them have involvement by mantle cell lymphoma. Walder's ring, splenomegaly. Splenomegaly can be sometimes huge and it can mimic like a splenic marginal zone lymphoma, hairy cell leukemia. So we have situations where it can mimic like a CLPD with huge spleen also. CNS involvement is usually uh, not very common at diagnosis, but it is seen most in lab setting, typically in blastoid mantle, and then involvement of orbital and lacrimal spaces and tonsils. Okay, so now what is the cell of origin, or that is the ontogeny of mantle cell lymphoma? So all of you know this. This is a germinal. This is a follicle, and this is a germinal center, and there is a mantle zone here. So the cell of origin for mantle cell lymphoma is a naive B cell, which is CD5 positive. Now you can see there are two pathways here in this diagram. One is one pathway is going via the mantle zone, not entering into germinal center, and then there is involvement of lymph node and external sites. So that's how a classical mantle cell lymphoma genesis occur. It is from a naive B cell, which is CD5 positive. So as it doesn't go to the germinal center, they are usually negative for germinal center markers like CD10 and BCL6. Now you can see it is classical mantle cell, and then from classical you have blastoid and pleomorphic. So these are the three common histologies that you see in mantle cell lymphoma. Almost 90% are classic, 10% are blastoid or pleomorphic. So now blastoid and pleomorphic can be seen upfront. Also, when the patients relapse from classical mantle cell, at relapse setting, they transform into a blastoid or a pleomorphic variant. So that happens when you have second hit, or you can say multiple cytogenetic aberrations in the form of TP53 Notch1 mutations, and that leads to this transformation to high-grade mantle cell lymphoma. So there is one group which is like a leukemic non-nodal mantle cell, which the leukemogenesis occurs via germinal center, and the cell of origin for this group of mantle cell is a germinal center memory B cells, and they involve mostly spleen, marrow, and peripheral blood, and you can say there are no involvement of the nodes. So these are broadly, you can have two different kinds of mantle cell at presentation. So all of us know that mantle cell is defined by a particular translocation called translocation 1114. So that leads to overproduction of cyclin D1, and that's how it kind of destabilize the cell cycle. But in a mantle, so what we expect in a lymphoma which is defined by a particular translocation, we expect the disease to be homogeneous. But surprisingly, mantle cell lymphoma shows a lot of heterogeneity, and heterogeneity inside in a single patient as well. Like you can see intertumoral heterogeneity. This is a PET scan of a mantle cell lymphoma, and you can see the involvement of spleen, the retroperitoneal nodes, and you can see the different FDG uptakes in different sites. So that's how the heterogeneity of mantle cell lymphoma is well established now. So even if it is defined by a particular translocation, this heterogeneity is mostly because of their genomic instability in the form of chromosomal abnormalities and mutations, mostly TP53 and ATM and Notch1 mutations. Now coming to the prognostic factor. So there are certain prognostic factors regarding which we have there is robust data, and that is in clinical use. And there are many prognostic factors which have potential for future use but not used currently for making treatment decision as well as prognostication. So if you see broadly what are the factors, age, as always, age one is one of the most important prognostic factor, performance status, CNS involvement. These are all which are expected. Now, something important is morphology. Now, you can see the morphology of mantle cell lymphoma is divided into three different groups: classical, pleomorphic, and blastoid. And you can see the morphologies here. Blastoid is something which is looks the morphology is more like a leukemic blast. There are large cells, lot of cytoplasm, lot of granules. Uh, Classical is more likely small to intermediate size cells. Cell size are not larger, and condensed chromatin. So pleomorphic is which is in between. So now blastoid and pleomorphic are bad, and classical mantle cell is better as a good prognosis, but blastoid and pleomorphic are bad in terms of morphology only. Now, key 67 is something which is very important for prognostication, and it is well established and in clinical use. That is, the cutoff used in mantle cell is 30%. Anything more than 30% is bad in mantle cell. Now, disease pattern, whether it is nodal or non-nodal. So as I discussed in my previous slide, non-nodal is a group which can be indolent and can behave and can have a better prognosis. So now there are a lot of other mutations like TP53, Notch1, ATM, SOX11. So these all have potential to be important factors to predict prognostication, but it is not in clinical use currently. Now, just like you have IPI in DLBCL, there is something called MIPI in mantle cell. So this was something which was, I would say, in 2008, it's a blood paper in 2008, and this was given by the European MCL network. And the four factors that was considered here is age, ECOG performance status, LDH, and WBC. So that correlate with the overall survival here. And you can see there are three different groups. There's a complicated equation based on these four factors, and after that you get a value. So depending on the value, it can be low risk, intermediate, and high risk. Anything more than 6.2 is high risk. You can see the risk groups are very well separated. Those who have low risk, the median survival had not reached yet. And those who have intermediate risk, the 5-year survival is around, the median survival is around 50 to 52 months. And those who have high risk, the median survival is around 29 to 30 months. So that you can, so this explains how the heterogeneity in terms of the clinical outcomes as well. So now there are a lot of improvisation upon MIPI by adding more factors to these four that I discussed just now. So that is addition of key 67, that it becomes MIPI-C, and addition of TP53 and Notch1 that came from Nordic and European MCL network group, where TP53 mutations as opposed to the deletion is bad. And if you see the Nordic data, the TP53 mutated patients have a median survival of 1.7 years as opposed to 12 years in those who are white. So TP53 and Notch is important for prognostication, but right now we don't have much evidence to recommend any particular treatment based on this prognostic factor. Okay, so these are prognostic but not predictive of any kind of benefit to a certain treatment. So now coming to, as I was discussing, so what are the different kinds of patient profile you are going to see in your OPD for a mantle cell? So it is 5 different groups. So as I discussed in my first slide, limited, low-grade leukemic, young and fit, old or unfit, relapsed refractory. Out of which the most common group is 4. Most of our patients will be old or unfit. The second larger group will be the 5, that is relapsed or refractory group. Third common group you're going to see is young and fit patients. Limited stage and low grade leukemia is very rare. In my last 3 years, I have seen 1 or 2 cases of limited stage disease. So it's very rare to get a limited stage mantle or a low grade leukemia. So now, how do we manage a limited stage disease? So in mantle cell, there is this controversy: is there really a true limited stage disease? Because as I told you that there is microscopic involvement of 88% if you do random biopsies by endoscopies in mantle cell. So this is the data from American Journal of Surgical Pathology. So what is the relevance of that? Much of it is not known, but almost 25% of patient will have macroscopic disease in the endoscopies. So now, as I said, it is 5 to 15% of total mantle cell is limited stage disease. And whatever literature available for the treatment are retrospective. People have used chemotherapy alone, radiation alone, combined modality. Interesting thing in mantle cell is late relapses can happen up to 12 years. So obviously the progression-free survival has to be confirmed, has to be looked into in future for overall survival benefit in mantle. So for any benefit in mantle cell, only relapse-free survival becomes little difficult. So what is significance, as I said, of that microscopic disease is not known. And any patient who is stage 2 or bulky disease, we have to treat like an advanced stage disease. So these are the data in terms of limited stage mantle cell, and you can see they are all retrospective. One data that I could find is of large patient size of 179, and you can see there are multiple ways they have treated 44 patient, chemotherapy, radiation, combined modality, and more or less there was no significant difference in terms of failure-free survival, overall survival, whatever you treat. But if you see the recommendation, stage 1, stage 2, we have to do a marrow, we have to do endoscopies to confirm that it is truly limited stage disease. And if it is so, then the patients can be treated with radiation alone. Any patient who have a systemic symptom or bulky lymphadenopathy, they should be treated like an advanced disease. So that completes the limited stage disease approach. Now, can you do wait and watch approach for any group of mantle cell lymphoma? Yes, there are certain group which you can do that. So, but as I said, there are very few, and one group is low grade leukemic. So that was the group that I discussed in my ontogeny slide, which have non-nodal presentation, hypermutated IgG gene, genetic stability, SOX11 negativity, non-complex karyotypes. So these are all, this is a group where we can actually think about if the patients are not symptomatic. Now there is another group which are nodal but very low disease burden, like small nodal size, no B symptoms, normal LDAs, Ki67 of less than 30%, classical histology, and largest diameter less than 3 centimeter. You can think about doing an observation policy. But you have to remember that the median time to treatment is around 12 months in these patients. So now how do we approach an advanced stage disease? So this is a beautiful flow chart. It's a nice review article by Dr. Wang. It's published in JCO. So in 2016. So if you see the approach to advanced stage mantle cell lymphoma, which is the most common group that we're going to see, depends on the fitness of the patient to receive high dose therapy. So if the patient is fit to receive high dose therapy, you have two approaches. Either use hypercVAD kind of approach, which is an MD Anderson approach, where transplant benefit is questionable. The other approach is using the classical RDHAP, RCHOP, RDHAP combinations, or MaxiCHOP like Nordic approach, and doing an autologous stem cell transplant and maintenance rituximab. So these are two approaches for fit patient. For patients who are not fit, which is the most common variety, you have RCHOP, BR, VR, CAP. We'll discuss each, and there is option of maintenance rituximab. If the patient is very frail, not fit for any kind of conventional chemotherapy, then you can use something like R square, R lenalidomide, and then use maintenance rituximab. So now let's come to the first group, patients who are young and fit to receive intensive therapy. So as I discussed with you, hypercVAD like an MD Anderson approach. So that is one thing. So there are so in young and fit mantle cell lymphoma, we'll discuss this in four headings. One is MD Anderson approach. Second is European MCL network using high dose cytarabine along with RCHOP. So that's an intensification with cytarabine on RCHOP given by European MCL network. Then we'll discuss about the role of transplant in young fit patient, and then lastly we'll discuss about the role of rituximab maintenance after transplant, and that was done by the LYSA group. Now coming to the first one, so this table summarizes all these four things. As you can see, this one is the MD Anderson approach of using hypercVAD with methotrexate RRC, and there is no transplant. You see, there is no transplant here, only hypercVAD methotrexate RRC. Now, Nordic approach is using MaxiCHOP. MaxiCHOP is when you have kind of escalated the dose of cyclophosphamide and adriamycin in the CHOP, that is using 1200 milligram of cyclophosphamide, 75 milligram per meter square of adriamycin, using RRC and transplant. So that's the Nordic approach. MCL2 is the second approach where they have incorporated rituximab, hydrocytarabine, and this is the outcome. And then third is using European MCL network approach, where they have used R-CHOP with cytarabine, like R-CHOP alternating with RDHAP along with transplant. And this is the study of maintenance rituximab after RDHAP induction, followed by maintenance rituximab, the LYSA group. So now this is the MD Anderson approach. It's a phase 2 data of 97 patients. Excellent response rate of 87%. Of course, these are in pre-PET era. And interesting thing was no patient underwent transplant here. And you see the 10-year outcome, there is a plateau here. Almost 30% patients are not relapsing at the end of 10 years. And the median progression-free survival is 8.8 years, those who are in CR after 2 cycles. So plateau in mantle cell lymphoma is shown by very few data, and this is one of it. So if you read mantle cell lymphoma, it's a incurable disease. No, every patient is going to eventually relapse. But when you see plateaus, there are very few data which has shown these plateaus, and so this is one. But important thing to understand is that 30% patient discontinue treatment due to toxicity, and there is high rate of stem cell mobilization failures. So significant data of efficacy could not be replicated well with Italian and swap group. So that's the usual story for our hyper-CVAD, where when these approaches are tried in different centers, similar kind of results are not reproduced, I would say. Now let's come to the second approach, that is European MCL network, where they have built upon R-CHOP backbone. So if you see, this is a randomized clinical trial of patients of mantle cell lymphoma less than 65 years of age, randomized to R-CHOP RDHAP alternating every 3 weeks, 6 cycles followed by transplant, and the standard arm was R-CHOP 6 cycles every 3 weeks. So at a median follow-up of 6 years, there was significant benefit in terms of progression-free survival, 9.3 versus 4.3 years. Huge benefit in PFS by just adding cytarabine to the backbone of the chemotherapy, R-CHOP, and transplant. Interesting is that they also did assessment of response rate before transplant, and it was significantly high in patients who received cytarabine. So adding cytarabine-based regimens with R-CHOP improves response rates as well as progression-free survival. But important thing to understand, there is no OS difference yet, and the 10-year update of European MCL network is going to be presented this year as in a couple of days. And this is the abstract I got, what I got from the AS abstract website. And if you can see that the median OS is not reached yet in the RDHAP arm versus 11.3 years in the R-CHOP arm. And you can see there is no plateau yet. You have patients still relapsing beyond 10 years. So that's what is the typical biology or history of or natural history of a mantle cell lymphoma. Now, what is the role of autologous stem cell transplant? What was the data that established that the patients of mantle cell lymphoma who are otherwise fit should undergo a autologous stem cell transplant? This was the data by European MCL network in 2005. It's a blood paper. And this was the era of pre-rituximab and pre-cytarabine. So these two things are very important to understand. This was in the era of CHOP kind of induction and randomization to transplant versus interferon alpha maintenance. And you can see that there was a difference in progression-free survival. So that is the only data that was available in a randomized way, that the role of autologous stem cell transplant in mantle cell lymphoma. So now the fourth thing I was going to discuss is about the role of rituximab maintenance after transplant using RDHAP kind of regimen. So this is a LYSA group study from France, and you can see the study design here: 18 to 65 years of age, 4 cycles of RDHAP, CR or PR randomized to rituximab maintenance versus wait and ward for 3 years, every 2 months for 3 years. So it has a huge benefit in terms of event-free survival. OS data is still immature. Median is not reached for either arm. You can see this is the event-free survival. There is a difference in terms of event-free survival, but median is not reached yet. And overall survival, the events are very less. But still, as rituximab has shown benefits in other studies as well, in the form of Nordic data also, and in patients of elderly DLBCLs as well, that I'm going to discuss. So it is practice changing, and we use rituximab maintenance for patients who undergo autologous stem cell transplant. So now, interesting thing is that we have discussed about role of high dose cytarabine. We discussed about autologous stem cell transplant in otherwise young fit patients. But what happens in real world? How many of the patients actually receive, even if they are fit to receive these treatments? This is a Flatiron database. It's an electronic database in US, and this was presented in 2021 ASCO meeting. Of around, you can see the numbers, huge, like 2,000 odd patients, and out of the 10% were blastoid morphology. Cytarabine containing regimen received only in 14% patients, and even patients of age less than 65 years, autologous stem cell transplant was used only in 23% patients. So there is a big disconnect between the real world and guidelines, if you say. So now let's switch on to let's move on to the elderly and less fit patient, which is the most common group that we are going to see. So what are the things that I'm going to discuss here? I will discuss about RCHOP, how RCHOP became standard of care in mantle cell, how the data of bendamustine emerged, what is the data of bortezomib-based induction in elderly or frail patient, what is the role of maintenance rituximab in elderly and less fit patient, and is there any non-chemotherapy-based approach that I was discussing about regimen of R square. So now this is a table where all the studies of older mantle cell lymphoma is there. So there are two approaches, RCHOP and BR. Now, if you see, there are two important studies using RCHOP backbone, and you see the numbers here, 267 to 43. When you see the BR-based regimen, you see 46 and 36. Why is that? Because these RCHOP studies like European MCL network studies were done classically on patients of mantle cell lymphoma. These BR studies, studies on BR-based regimen like STILL and BRIGHT were an all-comers low-grade lymphoma, out of which a mantle cell was one subset. That's why the numbers are very less here. So if you see, this is the first study. Again, it is from European MCL network. So we discussed one study of hydrocytarabine for European MCL network that was in the young fit patients. So this is again an European MCL network study in the elderly patients, age more than 65, using RCHOP as induction. And what was the comparator? RFC. I'll come in my subsequent slide. So this is the study that I was alluding to. So this is the second study of European MCL network in the age group of 60 to 65. And they compared two different kinds of induction regimen, RFC, that's fludarabine based regimen, and the experimental arm was RCHOP. And RCHOP was far better than RFC in terms of event-free survival. And after that, there was a second randomization of using rituximab maintenance versus interferon maintenance in both the arms. And maintenance rituximab was used till progression, and it is superior to using interferon maintenance. And there is an overall survival benefit of using maintenance rituximab in mantle cell lymphoma based on this European MCL network data. So there is a update that was published last year. This is a 6.7 years follow-up, median follow-up of the same study that I was discussing, and where the median OS for the patients who received RCHOP was 6.4 years versus 3.9 years for those who received RFC. And for those who received R maintenance, the median survival was 9.8 years versus 6.4 years. In the intention to treat population, the median survival was 7.9 years in those who received RCHOP followed by R maintenance. Now, interesting thing is those who received R maintenance after RFC, that is fludarabine based regimen, there was 22% unexplained death. So any patients who receive some purine analog in induction and then goes on to receive R maintenance, there is an increased immune suppression because of combined suppression of B and T cells, and that leads to a lot of infection related mortality. That's why the concern of using rituximab maintenance after bendamustine based induction. Now, whether we should limit the maintenance up to 2 to 3 years, or we should continue until progression. So this they have looked into on a very small group of patients, and when they found that those who received continuous maintenance rituximab after RCHOP, their outcome was better than those who received 2 to 3 years as a time limited maintenance strategy. So now how the data of bendamustine emerged. So as I was discussing in that table, remember there are two studies, BRIGHT and STILL, which established that bendamustine based rituximab is bendamustine based induction, BR induction is better than RCHOP. So there are two studies. One is STILL study. It is from Germany. It's a non-inferiority study. And patient group, if you see, as you are discussing, it's an all-comer low-grade lymphomas like follicular Waldenstrom, when Mantle was one group. And they were randomized to BR versus RCHOP, and the primary endpoint was progression-free survival. Now, second study is BRIGHT study. Again, it is a non-inferiority study. It's a global study, unlike STILL, which is a Germany limited study. The endpoint here is CR rates, complete response, and the regimens compared with RCHOP and RCVP. So there is a benefit. The study was positive. In both the studies were positive that our BR is non-inferior to RCHOP. With very less toxicity as compared to RCHOP. So this was the results. I am not going in detail for each study, but this was the conclusion of both the studies. The median progression-free survival in mantle cell group was 35 versus 22 if you use RCHOP, and BR showed improved CR rates as compared to RCHOP. there is no significant difference in overall survival because the events of for survival is not yet, events are less for overall survival. So why BR was adopted as an standard induction, even if the data for each group, it's a all-comer lymphoma, is because of the better toxicity profile, where there is less incidence of cytopenias or peripheral neuropathies or alopecia. So remember, important thing in BR versus RCHOP, both the studies, they never used a rituximab maintenance in the RCHOP arm, which is the kind of standard of care after the European MCL network data. So this is without rituximab maintenance, and we are comparing RCHOP with BR. So now there are a lot of improvisation that happened on bendamustine based induction at addition of cytarabine, low dose cytarabine. So we discussed about the role of cytarabine in young fit patient in European MCL network young study. So now this is a Italian approach where they want to add, they added 500 milligram meter square of cytarabine for 3 days with BR. The regimen is called RBAC. It's an interesting study, and the update is going to be again presented this year as in a couple of days. Phenomenal response rates in a very refractory group of patients. So it's a good approach, but the thing is toxicity when you add cytarabine to bendamustine. Now, addition of bortezomib to BR. So people have added bortezomib, bendamustine, rituximab with V. V is for Velcade, and it was presented this year ASCO. There is no difference. So I will show the data of VRCAP, that is addition of bortezomib to RCHOP, which improved this response rate as well as survival. But the same thing didn't matter when you're using BR based induction by addition of bortezomib. It was negative. So important is to understand that every drug you have to see what was the backbone they used. So now Nordic group tried to add lenalidomide with bendamustine, but somehow this approach was not really great because 16% patient develop second malignancies because Len and Benda both are known to cause second malignancies, and 40% patients have opportunistic infection. So it's not a good idea to add Len with bendamustine. So this is the study that I was referring to, adding bortezomib with RCHOP backbone, that is omitting vincristine. So whenever you giving bortezomib with RCHOP, you have to omit vincristine because of cumulative neurotoxicity. So as you can see, it's a very nice study where patients were randomized into RCHOP and VRCAP, and this is the regimen of VRCAP. Same like RCHOP, you use bortezomib 1.3 milligram per meter square, 1, 4, 8, 11. So you see the CR rate difference, 53 versus 48, and you see the difference in progression-free survival, almost 10 to 12 month improvement in the progression-free survival, and we have OS benefit as well. So it is one of the first study which has shown that there is an OS advantage when you add bortezomib to RCHOP. So this is the study, the result that was published in Lancet Oncology in 2018. The overall survival at 6 years, if you use VRCAP, is 56% versus 42% with RCHOP. Okay, so we have discussed about RCHOP, we have discussed about bendamustine, rituximab, and then we have discussed about VRCAP. So these three regimens we discussed in elderly unfit patients. Now let's come to a group of patients which are very frail, not fit to receive any intensive, so also any kind of chemotherapy also. So this is interesting and nice regimen of using R square, that is lenalidomide and rituximab as a upfront treatment. It's a phase 2 single arm study, and then there is rituximab maintenance as well. So intention to treat population, overall response rate was 87% with 60% CR rate, 2-year PFS of 87%. So toxicity, so just because there is no chemotherapy, you shouldn't assume that there is no toxicity. Grade 3, grade 4 hematology is 50%. So toxicities are there. So we have to see whether this kind of dose of lenalidomide is really feasible in our patients. So in our routine practice, it may not be feasible if it is a very weak and frail patient. We have to come down on the dose of lenalidomide. The dose they use is 20 milligram per day. Now 5-year PFS is 67% and overall survival 77%. So there were ways to improvise on that R2 backbone, because now when in a patient which is otherwise not fit for chemotherapy, you always want to add devise non-chemotherapy based regimens. So we had an R square backbone which has shown some good results. So then there is efforts to add venetoclax to that. So in an untreated group, so V plus R2, and that was presented as an in ASCO 2021, and there was effort to add ibrutinib to R square backbone. There is something called Philemon study, but that was published, that was done in the relapse refractory setting, and that was also full paper is published in Lancet. So this is the study where they have added venetoclax with len rituximab backbone, and You can see the study design here. Patients, the number of patients are only 28, and this is the way they have used len, venetoclax, rituximab, and the dose of lenalidomide, the venetoclax, they went up to 400 milligram per oral daily. And if you see the response rates to this particular regimen is gradually increasing at 3 months, 6 months, 9 months, and at the end of 12 months, when there are only 12 patients followed, we have 100% response rate in mantle cell lymphoma. But of course, there are only 12 patients out of 20 who are followed up to 12 months. So a phenomenal result with 90% MRD negativity in those who attained CR. So this is an interesting regimen. We have to look at the follow-up in terms of PFS and overall survival in subsequent meetings. So now, what are the important study that is ongoing and that is important to that may change practice in future? There are two studies, which Triangle and Sign. So Triangle is one study which is being done in young fit patients, where the important thing they were asking is that whether transplant we can avoid in few group of patients and by adding ibrutinib. So the backbone is same, R-CHOP, RDHAP, and add ibrutinib, and there is an arm where there is no transplant. Now, in elderly group of patient, the backbone was bendamustine rituximab, and they wanted to add it ibrutinib. So ibrutinib is coming upfront in these two studies where they are looking in randomized way. We'll discuss about BTK inhibitors, the role in relapsed refractory setting, which is well established now. Now let's come to the relapsed refractory setting. So the patients who relapse, what are the options? They have options of using, we have options of using chemotherapy, we have options of using BTK inhibitors, or in combination with chemotherapy, the role of BTK inhibitor plus venetoclax, and the role of CAR T-cell therapy. So now these are the chemotherapy-based regimens used in this as a salvage in relapsed mantle cell lymphoma, starting from BR, RBAC, BVR, CHOP, and R-GEMOX, GDP. So you see the response rates are around 40 to 50%, up to 80% also when you add rituximab. The CR is around 50 to 60%. But the important thing is that the progression-free survival, that whatever response you get, even in the relapse setting, is not durable. So you have got the median PFS of, you see, CHOP is 8 months, BOTE, CHOP, R-CHOP is around 16 to 17 months. So these are the kind of median PFS that you expect when you treat with chemotherapy-based salvage. Now let's come to what can we do with targeted drugs, and how good or bad they fare along as compared to chemotherapy. So typically what happens in mantle cell is, as the median age is 60 years and you treat these patients and they have good progression-free survival to upfront treatment, by the time they relapse, few of them may not be fit to receive any kind of chemotherapy. That's why the role of BTK inhibitors, venetoclax comes at those time. So this is an interesting study from Michael Wang, and it's an NEJM paper. It's a phase 2 study of using ibrutinib in relapsed refractory mantle cell lymphoma. If you see, the dose here is 560 milligram per day. You typically use 420 in CLL patients. This is a dose higher, and this is the group of patients that they have taken up to 5 lines of therapy, 1 to 5 previous line of therapy, 110 patients roughly. And you see the response rates, 67% response rate with 23% CR rates. But important thing, the response rates are more or less similar what you get in the chemotherapy, but median progression-free survival is quite good, 13 months, and median OS is almost 22 months. So it looks like that there are some patients who may have a durable response. So now this is an interesting data of all it's a pooled analysis of all data of ibrutinib. So people have used ibrutinib in the first relapse, second relapse, up to 5 relapse also. So what is the best line where you can use ibrutinib and to get the maximum benefit? So when they compared, they have divided the patients into 2 groups: patients who received after 1 line and the patient who received after more than 1 line. More than 1 line means second line also as chemotherapy, maybe third line also as chemotherapy, and then ibrutinib as a 4th line, versus first relapse. If you see the median PFS of those who relapsed after chemotherapy and received ibrutinib, it was 25 months. 10 months those who received after 1 line. So somehow this data established that, if you have a patient who can afford ibrutinib after first relapse, it seems the benefit is maximum, and if you use more in the later line of treatment, the progression-free survival goes down to almost 10 months. Now, after ibrutinib, we have data of acalabrutinib and janubrutinib also, which I'm not going in detail, but I'll just give a comparison of all these three BTK inhibitors. And all three are well established BTK inhibitors in relapsed refractory mantle. Now, if you just see, ibrutinib was used median of 3 lines prior treatment. Acalabrutinib data used acalabrutinib median 2 lines prior, and janubrutinib also median 2 lines prior. And if you see, the CR rates are better with second generation TKI, but if you have to remember, they have used after 2 lines. The median PFS also looks better in second generation TKI. It's 20 to 22 months if you use acala or janubrutinib. Important thing to understand is that the dose of ibrutinib here is 560, and there are concerns of toxicity. 40% patients had diarrhea, 4% had grade 3 or more diarrhea, almost 11% risk of atrial fibrillation. So we have toxicity issues with ibrutinib if you are using 560 milligram per day. So that is the concern in mantle cell. So that's why we have better TKIs with better response and better PFS. So that's why the field is moving towards using more and more second generation of TK in mantle cell. And if you see the janubrutinib and acalabrutinib data, apart from headache and the toxicities in acalabrutinib is diarrhea again. And the rate of atrial fibrillation is very less. It is 1% only in 2% only in janubrutinib and acalabrutinib, as compared to 11% in ibrutinib. So now this is the latest and most effective BTK inhibitor, pitobrutinib, that is the Bruin study. The name is LOXO 305. So this was typically designed for patients who progress or relapse after first and second generation of BTK inhibitors, like ibrutinib, acala, or so the basic concept of this drug is it's a non-covalent inhibitor, reversible inhibitor of BTK. So what the basic difference between first and second generation as compared to pitobrutinib is that the binding site is different. The binding site for ibrutinib is C481 domain of the BTK. Pitobrutinib bind in a different site in a non-covalent way. So that's why it also helps in patients who develop a resistance to ibrutinib. Now, mantle cell lymphoma group was 60 patients, and the dose finding, it's a basically a dose finding study, and 200 milligram once day was the dose which was found to be effective. So now, if you see the response rates, a very phase 1, it's a very early study, but if you see the response rates in mantle cell group, so they have used as an all-comer like CLL, MCL, Waldenstrom, and the response rates are modest. It's around 50%. In those patients who received at least a BTK inhibitor. So these are patients who have actually progressed, or they are refractory to first or second generation of BTK inhibitors. So in that, 50% response rate is definitely good. And then what is the data of venetoclax? So this is a phase 1 study of using venetoclax single agent in relapsed refractory NHL. So here the patient groups are mantle cell, follicular, DLBL, Waldenstrom. If I focus only on the mantle cell group, you see the responses are good as compared to at least DLBL, where you see quite a few progressions here. So this is a nice waterfall plot for mantle cell lymphoma. But important thing to understand is that though the responses look good in the waterfall plot, if you see the PFS, they are not very great. So these patients still progress in a couple of months. So using venetoclax as single agent doesn't look good in terms of the durability of those responses that you get. So that's why what happens. That's why this concept emerged of adding ibrutinib to venetoclax. So what happens is that we can give ibrutinib as a maintenance till progression, being a tolerable drug. Venetoclax after a certain point of time difficult to deliver in terms of its cumulative toxicity. So this is again an interesting study published in NEJM of using ibrutinib plus venetoclax in patients of mantle cell lymphoma, and most of them are relapsed mantle. 23 out of 24 were relapsed. Only one patient was untreated. And the study is called AIM study. So A stands for ABT199 is the name for venetoclax with ibrutinib in MCL. So they've used ibrutinib venetoclax until progression, and you see the PFS data. Median PFS is 29 months. So if you remember that PFS data for ibrutinib was around 10 to 13 months. And if you see venetoclax is again around 10 to 12 months. But if you see the median PFS, if you combine both, is 29 months, and median OSRE is 32 months. And in patients who are TP53 aberrant, of course, the response rates are not very great. The response rate is very good when the patients who are non-TP53 mutated. So we need a randomized study to answer this question, whether ibrutinib alone is enough or adding venetoclax improves its response rate as well as PFS. So we got something from phase 2 data, but this is a randomized study, simpatico study, which is comparing venetoclax ibrutinib versus ibrutinib till progression, and this will answer whether this combination using as a relapse in a relapse refractory setting improves survival. Now, what is their post-BTK progression? So that is an area where you have a patient who received ibrutinib or acalabrutinib and they progressed. That is an area which is unmet need, because the patients who progress after BTK inhibitor, the median survival is only 10 months. And why it happens that these patients do so bad? Because as the patient relapse in mantle cell, they acquire these TP53 mutations, and it is seen almost in 75% cases who progress on BTK. So that's why the response to further line of therapy is not very great. There are available options, and there are very few data in this regard, that is chemotherapy based regimens. If you see RBAC, again RBAC came here in the relapse refractory setting. It has shown some promise. And the second group, it's a RLEN Botidex, is a very small data of 5 to 6 patients. So obviously the data is emerging in this group. Single agent venetoclax, as I discussed, there is a response rate, but median PFS is not very great in this. The best is RBAC with a median PFS of 9 months, but you have to see the kind of toxicity they have. Now, LOXO 305 looks promising. It's a next generation of BTK inhibitor, around 50% response rate. So what is left in those group of patients? Allotransplant. So because if you really want a durable response, this patient should be counseled for allogeneic transplant, and you can use RBAC or any kind of BTK inhibitor or venetoclax as a bridge to allogeneic stem cell transplant. There is data that allogeneic transplant helps. There is data from EBMT group published 2 years back in BBMT, I think. So it is feasible, and mantle cell do have a good graft versus leukemia effect. But after this CAR-T data of mantle cell came, the role of allogeneic transplant somehow is again pushed beyond CAR-T. So we discussed about post-BTK group where the median survival is 10 months. So remember this. Now let's see what happened to those patients who received CAR-T. So this is JUMA-2 data published in NEJM. Again, they took patients of relapsed refractory mantle 1 to 5 lines of therapy. Again, standard, there are option of bridging therapy using acala or ibrutinib, conditioning regimen of fluci, and CAR-T dose was this. The primary endpoint was overall response rate. So I would say this is one of the best CAR-T results among all. And if you see the kind of patient here, 3 median line of therapy, most of them, almost every patient received BTK inhibitor. And I discussed what happens to those patients who receive BTK inhibitor. The next line of therapy is hardly anything we have. And most of the patients are refractory to BTK inhibitors, and you see the response rate, 90% response rate with 40% CR rates. This phenomenal response, and median time to initial response is 1 month. Median progression-free survival is 60%, and first 28 patients whose median follow-up is 27 months. You can see 43 patients have ongoing response without any further therapy. So this is, we are talking about a group where median survival was only 10 months in the pre-CAR-T era. Now you can see those responses, durability of responses, that is most important in mantle, and 43% are having ongoing response. We need to see the further follow-up. So this is one of the best, I would say. And in future looks that CAR-T is going to move ahead in the treatment line of mantle. Now, what is the right sequence? We have got bendamustine. Every patient receive bendamustine based first line. Now, after that, whether you should use chemotherapy, ibrutinib, what? So, what should be the right sequence? Whether chemotherapy should come before ibrutinib, or you should keep ibrutinib to third line. So, this is an interesting meta-analysis that was published this year. It's a Mantle first study. It's a retrospective collaborative data from all European countries. 261 patients, and the regimens they received in the left setting was BR, RBAC, ibrutinib. The important thing, median OS for all patients in this study, this first relapse, is 3 years. And one important prognostic factor they found was POD24. Any patients who progressed within 24 months of their initial treatment. So remember, all these patients who were taken in this study had received high-dose cytarabine-based induction with transplant as initial treatment. So they have only those patients who were taken, and then they relapse. So this is the outcome of only those patients. And you see those patients who are early relapses, like those who relapse within 24 months of the initial treatment, ibrutinib seems better. You see, this is the curve for ibrutinib, and it is far better than giving any kind of chemotherapy. Now, those patients who are late progressive disease, like more than 24 months, ibrutinib still did well, but chemotherapy also seems to be good in those group of patients, those who relapse late after 24 months of their initial treatment. So then how do you select treatment in those patients? So clinical trial is always first if the patient has an option. Allogeneic stem cell transplant should be looked into if you don't have option of CAR T in your center. If CAR T is available, definitely transplant goes beyond CAR T, as I said. If there is no feasibility of transplant, so then the option is ibrutinib. If the patient has any contraindication for ibrutinib, we can use conventional chemotherapy, that is RBAC, BR, RLEN, whatever you want. You can choose out of anything. So now let's come to the end of the presentation. Yeah. So what is known in mantle cell? So as I discussed, in young fit patient, the role of cytarabine induction is well established. Role of transplant and role of maintenance are right. So this is well established in young and fit patient if they are ready to receive this intensive treatment. Now, elderly and unfit patient, if I have to choose, there is no head-to-head comparison. There is only comparison of VR cap versus R-CHOP. There is no comparison of VR cap with BR, or there is no comparison of R-CHOP maintenance with BR. So there are ifs and buts if you compare both all these three regimens. But if I have to choose BR, I will choose over VR cap, and then R-CHOP comes the last, and then maintenance cetuximab post R-CHOP. So this is an elderly unfit patient. So what I will do in first relapse. So in first relapse, ideally the emerging data says that you should use BTK inhibitors over chemoimmunotherapy, but in our setting, definitely cost and continuous form of treatment is a challenge, and the tolerance of BTK inhibitor 560 also is a challenge. You don't have access, or so generic second generation BTK inhibitors, so we end up using ibrutinib, and ibrutinib 560 milligram, the tolerance is not as good as you see with 420 in CLL. So in that way, chemotherapy becomes a de facto second line in our patients, and then we somehow push BTK inhibitor towards the third line. Now, second relapse, I think BTK inhibitors should be used if you have feasibility of second generation Acala or zanubrutinib should be preferred over ibrutinib. Now, third relapse is clinical trial, CAR T feasible, RBAC, allotransplant, RLEN, botidexa, very small data. What are few unanswered questions that you don't know? Like for young fit patient, can we replace this intensive induction regimen with alternative regimens using novel agents and avoid transplant? So these are the studies that are going to answer this. Triangle study, which have incorporated BTK inhibitor, which R-CHOP, RDHAP, and they are asking whether you can forego transplant if you're using BTK inhibitor in young fit patients. Now, what is the role of MRD? Can we use MRD and then decide about transplant? So this is a study which is enrolling E4151. Based on MRD data, can you avoid transplant? Now, in MD Anderson, there are two approaches that has emerged, Window 1 and Windows 2 study. Window 2 study, they're again presenting this year as meeting in a couple of days. So as I discussed, MD Anderson approach is using hyper-CVAD without transplant, but they want, if you want to integrate novel therapy to hyper-CVAD, of course, you cannot combine ibrutinib to hyper-CVAD. So what they are doing is giving ibrutinib venetoclax as a kind of initial regimen, and then they are stratifying patients, and then deciding which patients should receive a kind of modified hyper-CVAD regimen, which they can continue ibrutinib venetoclax till progression. So now use of Acala, Len, venetoclax is again coming upfront. So these all are the study which are exploring these novel agents in upfront setting. And the basic question they are going to answer is that whether you need transplant and whether you need maintenance cetuximab in all patients. Now, can we use MRD guided therapy? No, I discussed this is again a question for research, and this ECOG study is going to answer that. And interestingly, an important thing is MRD in mantle cell is from marrow. It's a PCR MRD. By the real-time PCR quantitative real-time PCR assay. The E4151 study, they're looking at peripheral blood MRD by NGS and then decision of transplant. That's an interesting study. The results will have significant impact in terms of treatment in mantle cell lymphoma. Can you use these genomic techniques to decide on treatment? So as I discussed, the importance of prognostic scoring beyond MIPI is still investigational, because we are not deciding based on MIPI score to decide about the intensity of treatment. So again, there are studies which are going to answer this. Triangle studies has incorporated Notch1 and TP53 into their algorithm. So that will answer whether using TP53 based scoring, does it help? That is the answer that whether this. So if you see the Nordic data, they say that if you have TP53 mutation, the role of intensive therapy is hardly anything. The median survival is only 1.7 years, even if you use intensive approach. So these patients need some novel therapy upfront, like using ibrutinib, venetoclax, upfront use of novel agent as compared to intensive therapy. But you don't have practice changing data yet, and still, even if TP53 is mutated, my upfront treatment will not change. So that's why that's not still in the prime time to use. Next, the fourth important thing is, will CAR-T replace or cure for? So till now, what we have discussed is mantle cell lymphoma is an incurable disease. Most of the patients are going to relapse. We have seen hardly any plateau in very few survival curves. So CAR-T data looks promising, but still there are relapses. So in India, as I discussed, or in low middle income countries, the second line de facto becomes chemoimmunotherapy, and BTK is reserved for third line. And after BTK, the median survival is only 5 to 6 months. So we have an option of going for allo, which is not feasible in our country. So CAR-T seems feasible if it is available to our patients after failure of BTK. Okay, so I stop here. Thank you, and I'll see what are the questions in the chat box. Okay. So Akhil has asked, why won't we keep VR cap over BR? Yeah, so if you see the cross trial comparison of VR cap and VR cap looks good in terms of response rate and progression-free survival. But issue is tolerance. So because when you use bortezomib with anthracyclines, there is concern of neutropenia and severe neutropenia also. So as there is no direct comparison and BR is tolerable, most of your patients will be elderly, not very fit to receive any intensive treatment. So BR looks okay. So BR is adapted mostly based on his tolerance rather than, I would say, response. So okay, VR cap superior to R-CHOP in blastoid mantle cell lymphoma. Yeah. So blastoid mantle cell lymphoma is an unmet need in current time. So VR versus VR cap R-CHOP data, they didn't really look into blastoid versus classical. There are very few studies which have looked into this. If I remember correctly, MD Anderson data, hypersevere data, if you see the hypersevere data, they have looked into blastoid versus non-blastoid, those who received hypersevere. And if you see the data, the survival curves, it is on top of each other. That blastoid mantle have equal outcome to classical mantle if you use hypersevere. Difficult to kind of make out from that. So that is one data I could see. It looks good. So you need something more intensive in blastoid. The data of ibrutinib is not great with blastoid. The data of venetoclax also is not good. So novel therapies have a limited role. You need chemotherapy for sure. BR is definitely inferior. Now, whether you should use VR cap or hypersevere, it's anybody's guess. But if a patient is fit, I would prefer VR cap or R-CHOP over BR. If a patient is super fit, then I would prefer hypersevere. Difficult, and they need transplant, preferably allogeneic stem cell transplant. So that's about blastoid mantle. Now, newly diagnosed mantle cell lymphoma TP53 BTK inhibitor versus, yes, that's a very interesting question by Sumit. So TP53 mutation upfront, as I said, it came from Nordic studies where those who had TP53 are bad, and TP53 mutations, not the deletions, important. So we given it. So the thing is, as of now, based on TP53 mutation, there is no data that either BTK or chemo, which is better, right? So whatever you have is single arm studies, very studies which have done kind of post hoc analysis of the TP53 mutation data. If you see in current, the trials that are ongoing, like the triangle and sign. In sign, they have incorporated TP53. So if we see those results, and both TP53 notch one, will know whether adding ibrutinib helps. So as of now, in a patient who is newly diagnosed, if I do a TP53, what should I do with it? I don't know. Like using BTK inhibitor upfront, we don't have much evidence to say that that helps. So still chemoimmunotherapy remains my standard of care in this group of patients. I will ask Bhavsar sir and madam about their opinion, what they will do in a TP53 newly diagnosed mantle.
I think we don't do it routinely, Lingraj, so this won't arise. But as you said, their impact on prognosis is definitely there, but there is no data that they BTK inhibitor based therapy would be better than chemotherapy. Second thing is association of P53 with blastoid mantle. I think there we have contradictory data. Means BTK inhibitors or venetoclax probably were not holding on for longer. So there we go with chemoimmunotherapy and transplant. So I think, as you said, our approach would still remain chemoimmunotherapy.
Madam, you want to add anything?
No, nothing. So it's definitely prognostic, but it's not something like in CLL where you decide treatment based on P53 as of now. Answer is no. And as Mausab said, majority of times you have the adverse morphological as well as clinical features too in these patients. Having said that, there is no evidence that if you start with BTK inhibitors upfront, you're going to change outcomes. There isn't any data to say that.
Yeah, so one thing I want to add here that about TP53, so you see TP53 more and more in the relapse setting. As the patient relapse, if you do TP53, it is very high, and especially when they relapse after BTK inhibitors, it's almost 75% of them relapse TP53. So if you ask me, I have availability of everything to decide. I have CAR-T, I have allo transplant, so I have to decide, and then I have to use TP53 where I will use. Maybe in a patient who has progressed after BTK inhibitor and had a TP53 mutation, I will not use chemotherapy at least. In that case, maybe I will prefer a CAR-T or a venetoclax maybe. So that is one area where TP53 of use. Like in a relapse setting, if it is TP53, the outcome with chemotherapy-based salvage is not very great. So preferable, and CAR-T data has shown that probably TP53 doesn't matter if it is if you're using CAR-T. Maybe that is one thing that I can make out. But in upfront setting, it is difficult to make decision based on TP53. So what is cyclin D1 negative mantle cell lymphoma? Will treatment remain same like mantle? So cyclin D1 negative is not very common in mantle. So even if it is negative, there is something called SOX11 and that that somehow help us in diagnosing mantle cell. So the treatment is not different. It is same as we do in a standard mantle cell lymphoma. Any role of LEN maintenance? Any data regarding maintenance rituximab post R-CHOP RRC not undergoing transplant? So LEN maintenance, there is data of rituximab LEN maintenance, combined R-LEN maintenance. That is again an abstract I was reading yesterday. So that is going to be presented this year. So I think that data will say, I am not aware of that study, but there is no published data of using LEN maintenance. Sir, are you aware of any data, madam, LEN maintenance?
I think that study R square had a induction and maintenance part, no?
Yes.
The NEGM paper where
yes, sir.
Yeah, so there is data, and I think there is a ECOG randomized study which is randomizing patient after I think BR or physician's choice with 3 randomizations happening, rituximab with lenalidomide and in I think bortezomib also, but as you said, not the standard practice.
Yeah. Okay. Any data regarding maintenance rituximab post R-CHOP RRC? So post R-CHOP RRC is when you use R-CHOP RRC, you preferably you go for transplant. So without transplant, using RRC data is with bendamustine. No, that is not very great in upfront setting. So and there is no randomized data also that adding RRC with bendamustine helps. So if you're using R-CHOP RRC backbone, patient usually go for transplant. Non-transplant setting, usually using RRC only. How much it helps, we don't know. So if the patient is not for transplant, we should treat like the conventional approach. And then in that case, we should use maintenance rituximab. But there is data of, as I showed the European MCL network data of using maintenance rituximab after R-CHOP, and that data looks robust. So even if the patient receive R-CHOP RRC, using rituximab maintenance is important, because that's how it is done in European MCL network. So I would use rituximab maintenance even if there is no data in this group. So now, which new drug and technologies are affordable per patient? What is the standard of therapy offered to a patient with mantle? Do we routinely do transplant in young patient mantle? Yes, ma'am. So new drugs, I would say ibrutinib is available and we are using, but numbers are very less. Acalabrutinib, ibrutinib generic is available. Acalabrutinib is not affordable for our patients. It's the only innovator is available in the market. Now, what is the standard therapy? So, as I said, most of our patients are elderly. So, they usually receive bendamustine rituximab based treatment because most of them are not fit for transplant. Young patients, we offer transplant, but I think if you see the numbers of allo transplant, I don't think we have done any allo transplant of Mantle. Autologous stem cell transplant Mantle, we have couple of patients which we have done. If I remember vaguely, it is two patient or three patient. I think Sumit or Sachin sir can correct me if there or Anand sir. How many Mantle you have done? I am aware of one patient who had a GI disease, who underwent a colectomy and then transplant. And
so I can recollect 4 patients, Lingraj, who have
yeah.
undergone autologous stem cell transplant in the last 1.5 years.
Okay, great. So that's the number, ma'am. And allo transplant, I think we don't have any patient of allo for Mantle. Now, any role of CNS prophylaxis in blastoid mantle? Yeah, so blastoid mantle, as I said, is an unmet need. So if you're using something high dose methotrexate based induction, I think that's the best way to kind of take care of CNS, because blastoid mantle do have high risk of CNS relapse. So for a blastoid mantle, I would err on the side of giving some CNS prophylaxis, preferably if I'm using an R-CHOP or backbone, I will use mostly high dose methotrexate as my preferred CNS prophylaxis. If you are using a hypersevere, it has inbuilt high dose methotrexate. What is the madam has asked, Jaya madam, understand what the venetoclax affecting TP53 mutation, was wondering whether it could work in solid tumors. Ma'am, TP53 mutation, venetoclax, they have really not dissected that in venetoclax data, but ibrutinib looks okay if it is TP53 mutation in CLL. Rather, it is the standard of care, I would say, in CLL. But in Mantle, again, there are very less data. Venetoclax, I'm not aware that it is has anybody done an analysis on TP53 mutation. But ibrutinib in CLL definitely yes. So it seems like in a Mantle cell, if it is TP53, maybe ibrutinib maintenance is a good strategy. But venetoclax, I'm not aware.
Yeah, sure. Sorry, I think I misheard that. You mentioned that something is effective in P53 mutations, and that is what I wanted to understand.
Yes. So Amit has asked, if the patient is DS4 in PET post chemotherapy but good morphological response, do we need to consider second line or keep in observation? Yeah. So if the patient has residual disease at the end of chemoimmunotherapy, and if you are talking about a patient, likely you are talking about an elderly unfit patient, not for transplant, and in that situation, there are two approaches. One is I would prefer a rituximab maintenance, because why? Because if you the Nordic data has shown that if you use preemptive rituximab also in those patients who have MRD-based disease, there is improvement in PFS. So there is some data that rituximab maintenance helps in those patients also. So with an DS4, I would err in the giving rituximab maintenance. If it is R-CHOP, definitely yes, but if it is BR, I would prefer giving rituximab maintenance. Sir, anything else you want to add, Bhausef sir?
Yeah, I think it will depend upon whether it's a young and fit patient and what is your approach. But definitely, probably it is best not to act in elderly unfit patient and stick to the treatment.
Yes. Okay, so that's all for